this year, and happy Independence Day to all the Indians. So, when I was going through some news, I came across some information where I was surprised to know that India is not the only country which is celebrating independence today. Along with India, South Korea, North Korea, Republic of Congo, Bahrain, Liechtenstein. So around 4 to 5 other countries as well are celebrating their Independence Day today. So happy Independence Day to them as well. So today's live session, as already titled in the thumbnail, we will be discussing clinical examination aspect of diabetes mellitus. This is something which we commonly neglect because as dental students, most of us usually don't focus on the general clinical findings when it comes to various systemic conditions. It can be diabetes, it can be hypertension, so on and so forth. So in an endeavor to focus on these areas and to highlight their importance, because when it comes to case-based questions, when it comes to the final exam, we need to be equipped with this information as well. So what we'll do today is, so we'll go ahead with our session in the following format. So I will show you various images which are related to clinical examination in the context of diabetes mellitus, and then we'll briefly have textbook review or article review regarding those conditions. Okay, so it'll be more or less, as mentioned in the title, an image-based discussion. So we'll try to cover as many images as possible. I have some 5 to 7 images max, so it takes maybe 20-25 minutes to complete them, and after that, okay, we'll have some Q&A, following which we'll go ahead with MCQs discussion. So if you have observed last time, after completing the last live session, we posted multiple choice questions, 5 multiple choice questions related to hot tooth in the community page. Around 100 students have participated in those questions, in answering those questions so far. So after the session concludes, we'll post some 5 questions, maybe 5 multiple choice questions in the community page, right? So this is how I'm planning to conduct this session. And if you have any queries, you need any further guidance, or you need any further clarification, you can always use the chat box below. Okay, so before we start, coming to the introduction of diabetes, I was referring to Davidson and also various PubMed indexed articles, StatPearls. There are many online resources which are available, standardized resources which are available, which provide authentic information. And when I was going through diabetes mellitus for the past 24 hours, I have been extensively going through this entire topic, and I've completed the entire chapter that is available in Davidson. And after reviewing several articles, while referring certain information related to the images which I'll be presenting now, I was surprised to see some of the statistics which are mentioned about the number of people suffering from diabetes globally. In fact, in the introductory part of Davidson, the Essentials of Davidson, the second edition which I have, in the introductory part, they say that around 336 million or so are suffering from diabetes globally way back in 2011. And it is estimated that by 2030, according to the textbook, according to Davidson, we can have around 550 plus million people suffering from diabetes, which means 500 million. And like the global population is around 7 billion maybe. So by 2030, 500 million. And then I was going through, like, since my Davidson is, I thought it's like a previous edition. So why can't I just go through the latest numbers, latest statistics that are available online? So when I was going through the World Diabetes Association's official website, International Diabetes Federation, IDF, in their official website, where they're clearly mentioned, November 14th is World Diabetes Day, as you already know, most of you, November 14th. And as mentioned in the website, I was really shocked to see the numbers. What's mentioned in Davidson, we have far surpassed the numbers in terms of people suffering from diabetes. And I just wanted to present that information to you, because this diabetes which I'm talking about, it is not just a topic which we need to be thorough with for sake of giving entrance exam or for sake of answering questions in entrance exam. Just imagine this. I'm sure most of us in our families have members who are suffering from diabetes. In my home, both my parents, my father is in a pre-diabetic stage. My mom has diabetes, diagnosed some 30, 35 years ago. And I have closely observed the kind of adverse effects, the complications that they face as a consequence of diabetes, as a consequence of not maintaining the prescribed glucose levels. According to WHO, fasting has to be, for normal patients, the fasting blood glucose levels have to be in the range of 70 to 100 milligrams per deciliter. But given the food habits we have, the postprandial, anyways, it should not exceed 200 milligrams per deciliter in order to diagnose as diabetic. But the food habits, given the food habits we have, given the lifestyle that we have, especially South Asians, the diabetes is spreading alarmingly at an alarming rate. Now let's look at the numbers. Numbers given in the official website. The IDF Diabetes Atlas, IDF stands for International Diabetes Federation. It provides the latest figures, information and projections on global impact of diabetes, according to which 537 million adults, that is 1 in every 10 members on this planet, is or were living with diabetes in 2021. This is old information. I mean, this is past. They're not even talking about present or future. 537 million adults, that is 1 in 10, were living with diabetes in 2021. This number is expected to rise to 643 million by 2030, 100 million more than what's mentioned in Davidson, and 783 million by 2045. Look at these staggering numbers. And also they say almost 1 in 2 adults with diabetes, that is almost 44% of the patients, they remain undiagnosed, which comes to around 240 million. And the majority have type 2 diabetes, type 2. And more than 3 in 4 people with diabetes live in low and middle income countries. If you carefully observe, low and middle income countries, poor lifestyle, poor dietary habits, so on and so forth. Also, accessibility to healthcare, even that plays a very important role, right? And 541 million adults are at increased risk of developing type 2 diabetes. Another half a billion are at increased risk. And more than 1.2 million children and adolescents between 0 to 19 years live with type 1 diabetes. And diabetes caused around 6.7 million deaths in 2021. And diabetes was responsible for at least $966 billion in health expenditure in 2021. That is 9% of total global total spent on healthcare. 100 rupees if you spend, almost 9 rupees is for diabetes on a global level. And 1 in 6 live births, 21 million approximately, are affected by high blood glucose in pregnancy or hyperglycemia. These numbers are very staggering. I mean, once you get these numbers, I mean, it's not really surprising to some extent, even though these numbers are staggering, given the lifestyle we have, given the dietary habits that we all have. I don't think it's a big surprise, right? I mean, 500 million people globally, and look at the amount of burden it has on our healthcare system. So my point is, we can discuss about diabetes, we can discuss about clinical symptoms, examination, management, pathophysiology, so on and so forth, various types of diabetes. But unless and until we personally do not institute changes either in our lifestyle or dietary habits, then even we will not be spared as individuals. So unless you feel the pain of it, maybe you will not recognize the intensity. So I'm sure most of you will feel the pain, given the fact that, as I said previously, majority of our homes, especially in South Asia, right, we have at least one individual in our family, close relatives or distant relatives, whom we know to be a diabetic. Isn't that the case? So keeping all these things aside, what is this diabetes mellitus according to Davidson again? So they say it's a syndrome rather than a disease. It's a syndrome. It's a complex syndrome which has various manifestations leading to derailed metabolism of glucose, derailed glucose metabolism. And in fact, it has something to do with either absolute or relative deficiency of insulin, because in case of type 1 we see there is absolute drop in insulin, right, which is secreted or produced by islets of Langerhans, pancreatic cells, beta cells. However, in case of type 2, even though the insulin is there initially produced by body normally, as time progresses, because of the increased sensitivity of cells to insulin, the insulin production also drops. So if you carefully observe the definition or try to understand what this diabetes mellitus is all about, I'm not talking about insipidus, so we're talking about diabetes mellitus. So it's a complex syndrome where there is derailment in glucose metabolism leading to long-term complications, microvascular as well as macrovascular complications, and it is associated with absolute or relative deficiency of insulin. And as you know, insulin is produced by pancreas, islets of Langerhans, beta cells, and alpha cells produce glucagon. You know how insulin acts. So the food that we take, it is broken down, carbohydrates are broken down into simplest molecules, glucose. Glucose is very much essential. Glucose in blood is very much essential for our brain, because brain cannot accept other sources of energy. As you know, there is something called as blood-brain barrier, and free fatty acids or other compounds cannot enter or cross this barrier. So glucose is the only means through which, is one of the only means through which the brain gets its energy, and even the rest of the body, the rest of the cells. So glucose in blood is essential. So this glucose in blood, fasting glucose levels, according to WHO latest guidelines, World Health Organization clearly states that it has to be in the range of, fasting is considered very important when it comes to measurements, it has to be in the range of 70 milligrams to 100 milligrams per deciliter, fasting, which translates to around 3.9 millimoles per liter to around 5.6 millimoles per liter. Try to remember values in both the units if possible, keeping entrance perspective in mind. So this is a very finite range within which the blood glucose levels are monitored in majority of the populations, even though there can be variations depending on the socioeconomic status, depending on the lifestyle, so on and so forth. So the point here is, once carbohydrate is broken down into glucose in blood, then it rises and its levels are maintained. There is hypoglycemia, and then insulin comes, it is released in portal circulation, you know the mechanism, and then it inhibits gluconeogenesis, it inhibits glycogen lysis, right, because already glucose is available because of the food that you have taken, and then try to maintain the blood glucose levels. That is what we know about insulin action. And when the insulin levels drop after a meal or something like that, during or between the meal, then obviously there is lipolysis, which is promoted because of drop in insulin, and then free fatty acids. So this is normal mechanism which we keep hearing right from the beginning of our professional journey in the form of physiology, right? So what's happening here, as you know, in case of type 1 diabetes, type 2 diabetes, or even there is something called as gestational diabetes, also late onset autoimmune diabetes. There is another diagnostic term, and there are different other types of diabetes mellitus. In all these cases, the glucose values in the blood, the glucose metabolism is being derailed because of various reasons. We'll not go into the details of pathophysiology and so forth. We'll focus on the clinical manifestations, or we'll rather focus on the clinical aspect of this, like clinical presentation of diabetes mellitus. For example, you came across a patient, or you came across your neighbor, right? Have you ever observed that in the folds of, in some middle-aged people or even older individuals, in the creases or in the folds of skin in the neck, you'll find some dark pigmentation? Have you ever observed that? I'm sure most of you might have seen that in person. So what could that be? It has something to do with acanthosis nigricans. Similarly, various other manifestations like in fact, I have an infographic which I have picked from Davidson, and then we'll try to present the same. Like for example, another patient you came across, and another neighbor, forget about patient, you came across a neighbor who complains of wound not being healed. So your knowledge about diabetes mellitus. Even though you're a dentist, you should understand that you're also a physician. You should understand this systemic manifestation so that you can treat the patient or guide them accordingly. If not treat, at least guide them accordingly. If such patients come for dental treatment, then how do you address it? So never assume that this session or this endeavor of conducting this discussion is not just keeping the entrance perspective in mind. It's for us to holistically understand the concept of diabetes mellitus, the syndrome of diabetes mellitus, how to manage it, how to detect it, and what are the various ramifications or complications associated with it. Right? So this is the infographic, which I would like to show to you first. So is it too dark? I think it's too bright. You can see, I mean, yeah, I think now it's pretty much clear. So Davidson, second edition, The Essentials of General Medicine by Davidson. So you can have a look at this particular infographic where they have clearly mentioned about various clinical manifestations, right, in diabetics. So we'll just go through them one by one in the form of images. Okay, so I have some images for you and I'll present them. Hi Sujay. Hi Naveen. Very good evening. Yes, thank you Naveen, and glad to hear from you as well. So first and foremost, observe this image. So observe this image carefully, and then simultaneously, as I'm presenting you this image, I'll be reviewing some literature which is related to this particular image. Okay, yeah. So this is given as one of the clinical manifestations or signs or symptoms of diabetic patients. So you can see there is contracture, right? Especially the ring finger, if you carefully observe. Yeah. So this is Dupuytren contracture, Dupuytren, Dupuytren contracture or Dupuytren disease. So if in case you come across any image-based questions with a context that is given to you, then you should be able to identify what this is. Okay, yeah. Usually they don't just give you the image, we'll also give you the context. Anyways, we'll use our community page in order to post such image-based questions after the session. So this is Dupuytren's contracture. So very briefly about Dupuytren's contracture, it's a predominantly myofibroblastic disease that affects the palmar and distal fascia of the hand and results in contracture deformities. The most commonly affected digits, as you can see, are the ring finger, the fourth finger, and the fifth finger or the pinky. The disease begins in palm as painless nodules. In fact, you don't notice nodules here, but you can see striations here. The disease begins in the palm as painless nodules that form along longitudinal lines of tension. The nodules then form cords. So what you can see here is a cord. Okay, so extending from the center of the palm towards the ring finger. So the nodules form cords that produce contracture deformities within facial bands and tissues of the hand. We still have some information related to Dupuytren's contracture, but anyways, the information is available on standard PubMed indexed articles as well as textbooks. You can go through it in detail. So as I said, one of the key objectives of this session is to present these images and to discuss the pathologies or the clinical findings in brief. Okay, so this is Dupuytren's contracture, where you can see a classic picture of fingers being contracted because of nodules and cord formation. It's considered as a myofibroblastic disease seen in many conditions and including diabetes mellitus. That's what I want you guys to keep in mind. Okay, next. So what is this image representing? So this is another clinical manifestation, the clinical finding in diabetic patients. So I'll just turn the image. So in this they're talking about CTS, carpal tunnel syndrome. especially those who play these video games or those who use keyboards excessively. I used to do that previously, several years ago, even till today. I used to have this burning and tingling sensation. So the beginning of CTS, carpal tunnel syndrome. So let me just get back to that clinical picture again. So carefully observe the presentation. So it occurs when the median nerve is compressed at its as it traverses the carpal tunnel. So median nerve compression is, yeah, it is considered to be because of median nerve compression. So the primary factor contributing to the onset of CTS is elevated pressure in the carpal tunnel, which is demonstrated in this infographic. I mean, in this illustration. Okay, so you can clearly see here the median nerve and compressed median nerve as mentioned here. Okay, right. So let's get back to the clinical image again, clinical picture. So CTS occurs when the median nerve is compressed as it traverses the carpal tunnel. The primary factor contributing to the onset of CTS is the elevated pressure within the carpal tunnel. The typical initial signs of CTS include pain, numbness, paresthesia, which affects the first 3 digits and the lateral half of the 4th digit. The clinical presentation is very important. And symptoms of CTS can exhibit variability with pain manifesting at the wrist, which I experienced personally, involving the entire hand, especially during my childhood when I used to play this bike game, Demo Rash. I used to have this in 1990s. I used to have this wrist pain. And potentially radiating up the forearm or extending beyond the elbow. Pain associated with CTS doesn't typically extend to the neck. As the condition advances, individuals may experience hand weakness, diminished fine motor coordination, so the dentist should be extra cautious, clumsiness, and eventual atrophy of thinner muscles. So this is an image which is representing CTS, carpal tunnel syndrome. Okay? Yeah. Now let's move on to the next one. So what is this? So you can see as if you are pulling a trigger. So this is trigger finger, another clinical manifestation which can be evidently seen in diabetic patients. Not all patients, but maybe in some patients, depending on the nature of symptoms or extent of symptoms that they manifest. Trigger finger. So this is trigger finger, or it's also called as tenosing tenosynovitis. The information which I am giving to you is standardized. It's from PubMed indexed articles as well as from Davidson. Okay. So as I said, as I mentioned in the pinned message in chat box, have your notes ready, have your pen with you so that you can make a note of all these points, and it will help you answer questions with confidence at a later time. So this is also called as trigger finger or tenosing tenosynovitis. It's a prevalent condition arising from repetitive use of 4th finger and thumb. This results in significant functional impairment and tenosynovitis within the flexor sheets of both the fingers and thumb. The development of trigger finger is attributed to a narrowing of flexor pulley sheets. I'll show you the illustration of those pulley sheets, and accompanied by hypertrophy and inflammation at the tendon sheath interface, leading to formation of nodules on the tendon. Although trigger finger classically involves the A1 pulley sheath, here you can actually see all the pulley sheaths which have been named A1, A2, A3, A4 and A5. So trigger finger classically involves A1 pulley sheath located at the metacarpophalangeal joint. Yeah, as you can see, which is the proximal section of the tendon sheath. It can also occur at A2 and it can also occur at A3. And what is A2 and A3? You can clearly see in these illustrations. If it is not clear, we'll post all these images in the community page in the form of a document, or we'll figure it out how to post these images. Okay. Yeah, I'll try lowering the brightness once and we'll see if it works out. I think you can see that now. Yeah, I think it's much more clear. So A1 is commonly implicated or involved. Okay, and we're talking about trigger finger. Okay, another clinical manifestation or clinical examination part, you can say, clinical symptoms. Now Let me just go through the other image. So this is the patient's leg, and it's the shin, the anterior portion, the shin, and you can see some inflamed area there. So what is this? I think we'll put it in a vertical orientation. Yeah, this is much better. So this is termed as necrobiosis lipoidica. Necrobiosis lipoidica. So it's a rare chronic idiopathic disease characterized by collagen degeneration, kind of necrosis you can say. It's called as necrobiosis lipoidica. Okay. So it's a rare chronic idiopathic disease characterized by collagen degeneration that causes skin lesions, typically on the anterior shin surface. The disease is classically associated with diabetes mellitus, typically type 1, make a note of it, and carries a risk of ulceration, as you can see in this particular illustration. Skin changes include thickening of blood vessel walls, collagen deterioration, granuloma formation, and fat deposition. Hence, it is called as lipoidica, necrobiosis lipoidica. A major complication of disease is ulcer formation, often occurring after trauma. Infections are uncommon. Moreover, if necrobiosis lipoidica becomes chronic, it may rarely progress to squamous cell carcinoma. Another important point which you can make a note of. It may rarely progress to SCC, squamous cell carcinoma, right? Yeah. So necrobiosis lipoidica. Okay, fine. What about this? You can see some redness, you can see some clear demarcation in this particular illustration. What could this be? So you can see a very circumscribed and very delineated kind of lesion here. Yeah, I really appreciate your answer, Gopal. It's not fungal infection. It is, yeah, and you can include that in differential without any doubt. Granuloma annulare, GA. So what is this granuloma annulare? It's a cutaneous granulomatous disease of unknown etiology. It is idiopathic in origin, but also associated with multifactorial in origin, but also associated with one of the factors could be diabetes mellitus. It's the most common non-infectious granulomatous disease. Do make a note of this point. Most common non-infectious granulomatous disease. The disease is benign and often self-limited. Benign and self-limited, as you can see. The self-limitation and granuloma annulare usually presents as erythematous plaques or papules. In this case, it is in the form of a plaque arranged in an annular configuration on the upper extremities. Okay. In addition to the more common presentation termed localized granuloma annulare, other clinical variants also are present, which include generalized, perforating, patch, subcutaneous, etc. Despite being a benign disease, it can be associated with a more serious condition such as malignancy or even HIV. So you can include that in the differential aspect. Okay. Yeah. So this is granuloma annulare. And then penultimate. So what could this be? This is better. You can see some whitish patches, uneven discoloration on the palm, on the hand, on the dorsal side. Yeah. So what this could be? Also, one of the manifestations in diabetes patients, vitiligo. You might have heard of this vitiligo. So vitiligo is an acquired pigmentary skin disorder by absence of pigmentary cells from the epidermis that results in white macules or patches. Yeah, it can be white macules or patches. The condition is usually associated with few autoimmune disorders, with thyroid abnormalities being the commonest one. So vitiligo, autoimmune, thyroid. You can just make a note of these points. The etiology of vitiligo is unknown, but there are different theories to explain its pathologies. Vitiligo presents clinically with signs and symptoms of white spots on the body distributed symmetrically and more obvious in people with dark skin. I'm sure you might have come across many people presenting with this vitiligo on your day-to-day basis, or at least on televisions, or we have one of the politicians in our state who has vitiligo. Yeah. And finally, so this is something which I started our live session with. You can make a guess. So what is this dark patches, dark pigmentation, and what would be your probable diagnosis? As we are discussing, the topic is clinical presentation in diabetic patients. It can also be found in other conditions, even in malignancy. So what is the diagnosis? So let me just briefly review the information related to this lesion. It's called as, good, acanthosis nigricans. Yeah, you're right. Very good. So what is this acanthosis nigricans? It's a velvety darkening of skin that usually occurs in intertriginous areas. Intertriginous areas means areas where two skin surfaces rub or touch each other. It can be armpits, it can be neck surface, etc. So this hyperpigmentation has poorly defined borders, as you can see, usually occurs in skin fold areas such as the back of the neck, axilla, groin, and may include thickening of skin in those areas. Acanthosis nigricans is most commonly associated with diabetes and insulin resistance. Do make a note of this point. But rarely it can be a sign of internal malignancy as well, differential. It can also occur with hormone disorders, with the use of certain medications such as steroids, glucocorticoids, and even oral contraceptives. Yes, acanthosis nigricans indicating resistance to insulin. Very good. As I mentioned, it is most commonly associated with diabetes and insulin resistance. Good. So those who have participated, I really appreciate you guys. And Sarita, I've seen your comment, but I didn't get time to respond as we were discussing those images. Thank you so much for your lovely words. And I'm glad you said the voice is soothing. I know it is. So this is what I wanted to highlight in this particular session. And as I started this live session, I just want you guys to keep in mind that this is, let's not restrict this topic for entrance, for sake of answering questions in entrance exam. That anyways we'll do. If not through this live session, you can study by yourself, or you can get through various other resources, and then you can excel in your own way when it comes to entrance preparation, answering questions, so on and so forth. But another main objective of this session, along with subject-wise or academic discussion, is diabetes is something which is like spreading like wildfire. We've seen the numbers. The International Diabetes Federation, IDF, especially Sujay, since you are in public health dentistry, I'm sure you'll make a note of it. In the beginning of the session, we're giving you some numbers. IDF clearly states that 500 million are already affected with diabetes globally, and it is estimated to rise to 750 million by 2060 or something like that. Now, keep these numbers aside. 1 in 10 is a non-diabetic as per these numbers. And let's keep everything aside, but look at the lifestyle that we're leading, the kind of food habits that we have. In fact, I think I already mentioned, I already highlighted this on social media. I stopped taking added sugar, white sugar. On April 20, 2024, I made a decision in my life that I wanted to stop the intake of added sugar or table sugar or white sugar. And from then, what I've realized is a simple decision, even though it was very difficult to take. It's a very profound decision, given the fact that sugar is everywhere. But a simple decision like that will have a drastic impact on our health. See, in fact, there was one study which said, clearly mentioned that when you take added sugar in excess quantities, added sugar, not the natural sugars, the added sugar, glucose level spikes and then it drops after some time. So there is this imbalance in glucose levels, which leads to mood fluctuations, so on and so forth. And high glucose levels are also associated with various ailments, as mentioned in this wonderful book called Lifespan, in which the anti-aging scientist David Sinclair talks about the ill effects of eating too much, eating lots of sugars. In fact, they say, surprisingly, and I think most of you know this, if you go on a fast, if you're in calorie restriction, if you do fasting, intermittent fasting, or any kind of fasting, the radicals which are generated, oxygen-free radicals, or whatever radicals which are generated in our body will get destroyed. And as a consequence, zombie cells or senescent cells can be destroyed or will get destroyed. Cancer-causing cells will get destroyed. That's the power of fasting, and that's the reason why in our culture, fasting has been intrinsic. When I mean to say intrinsic, it has been deeply ingrained in our culture. Like we have like Shravan Sukruvaram, we have so many terms for that in our Telugu culture, like even in Hindi, even in different religions and languages. Every Friday or every Sunday, there is this fasting which has been incorporated. You take Ramzan, entire month, there is fasting. So fasting, the power of fasting has been clearly documented, not only in science, but also in our culture, but also in our history. And once I've made that decision to cut down the sugar, what I've noticed is literally 90 to 95% of packed food has been eliminated from my diet. In fact, 100%, I'm not taking any high processed food. Because what I've noticed is, even when I was in Malaysia last month, for 1 month I stayed in Malaysia, even whenever I was hungry, whenever I went to any store to get some packaged food without added sugar, it was highly impossible, because almost every high processed food or packaged food contains added sugar. And because of my decision of not to take this added sugar, I could eliminate saturated fat, because the packaged food contains a lot of saturated fat, contains a lot of chemicals, artificial preservatives, flavors, so on and so forth. So as a consequence, the entire diet has changed. And you might ask me this question, like, is it sustainable? Trust me when I say this, it is 101% sustainable. Initially, for the first 2 to 3 weeks, 21-day challenge, I took it up as a 21-day challenge. And initially it was a struggle, because I love sweets. I used to request my mom to make some sweets. I learned cooking some sweets. I eat a lot of sweets. I used to eat a lot of sweets. But after those initial 2 to 3 weeks, once a new activity becomes habituated, it gets habituated. You get habituated to that new activity. Then you'll not feel the pain, or you'll not feel the pressure. In fact, one of the most significant things that I've noticed personally with this dietary change is I've lost cravings. No more cravings for sugar, no more sugary drinks, nothing of that sort. And another major change which I've noticed in me is there are no mood fluctuations whatsoever. And another major change is there is no fluffiness, there is no water accumulation whatsoever. You're able to sleep on time and wake up on time, and things are improving drastically. It's been almost 4 months. By August 20, I think April, May, June, July, August, it will be around 4 months that I've completely stopped this added sugar. And it's a lifelong decision. And then I realized that it's going to be my lifelong decision. So the point I'm trying to make here is, it all starts from us. Dietary changes, lifestyle changes. I started working out for the past 15 days after I started returning, after I came back from Malaysia. And then I realized we don't need weights to work out. Even though I use weights, we can use our own body weight. So the point here is, dietary changes, lifestyle changes, these are completely our choice, 100%. And why is it I'm talking about them here? Because diabetes, especially type 2 diabetes, which is widely prevalent nowadays, as per the statistics that I mentioned, is largely because of improper dietary and lifestyle changes. Even in Davidson, they've clearly mentioned that if you observe the management part, one of the first things that they mention is 50% of the patients do not need oral hypoglycemic drugs. They don't need these hypoglycemic drugs at all, 50% of the patients. With lifestyle and dietary changes, In fact, that's what many people are doing. In fact, my mom is known diabetic for 30 years and she stopped medication for almost 3 years. It's because of dietary changes. Dietary changes are the key. Lifestyle changes are the key. You might think like I'm young or we're all young, we're in 20s, I'm in my 30s, so why should we bother now? This is all the foundation. If you neglect now, it's going to have the consequences, if not now, maybe later. And you know the complications of diabetes. I'm unfortunately seeing them in my own mother. Microvascular complications, macrovascular complications. Once you go through Davidson, information given over there, or any PubMed indexed article, or any standard article, it's mind-boggling. Microvascular complication, they talk about retinopathy, blot appearance, cotton wool appearance. We'll go through all those in subsequent live sessions. Retinopathy, diabetic retinopathy, because of microvascular changes, hyperglycemia, poor glycemic control, it can lead to diabetic retinopathy, which is one of the most leading causes of blindness in diabetics. This is not exaggeration, this is information which I'm presenting you from Davidson, which I reviewed yesterday. So diabetic retinopathy, diabetic nephropathy. My mom has end-stage renal disease and she is on dialysis now, and it takes a lot of pain to be in that situation. And why is it happening? So as I mentioned previously, we can take care of our choices of diet and lifestyle. Diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, peripheral neuropathy, sensory loss, motor wasting, so on and so forth. So many complications just because of microvascular complications. There is a range of complications we're seeing in patients. And when it comes to macrovascular complications, it can lead to MI, myocardial infarction. It can lead to stroke. It can lead to TIA, transient ischemic attacks, whatnot. So there are n number of complications which can be, in fact, they clearly say in Davidson, we can escape, patients with diabetes can escape these long-term complications. The textbook says, usually we don't come across these terms in standard literature, but clearly Davidson states that a person who has excellent glycemic control can escape from the complications of diabetes. So those who are watching this live session, get your lifestyle right, let's get our lifestyle right, let's get our dietary habits right, and let's convey the same to our elders or to our family members. Okay, because this, if not addressed properly, will lead to a lot of physical pain, emotional pain, financial pain, whatnot. Right? I'm telling you with experience and pain. So I hope this session is helpful. And before I conclude, one thing which I wanted to highlight is in an endeavor to maintain excellent glycemic control, there is a chance that patients might slip into hypoglycemia, which can lead to death. It is the most dangerous complication of diabetes, hypoglycemia. And according to WHO, hypoglycemia is termed when the levels fall below 70 milligrams per deciliter or 3.9 millimoles per liter, or according to Davidson, it is 63 milligrams per deciliter. But whatever it is, you keep the values in mind, the latest information that's available online as well as in the latest edition, and most importantly, if this knowledge of ours is not translating into reality, mark my words, there is no point in studying at all. If our knowledge of diabetes mellitus or any pathology for that matter, or any ailment for that matter, it can be dentistry, it can be medicine, if our knowledge is not translating into practicality in our own life as well as in the life of our people in our family or in our environment or in our universe, then there is no point in getting this knowledge. If you think, or if we are under assumption that this knowledge is just for sake of marks and ranks, it would be one of the fullest, stupidest approaches that anyone can ever undertake. Unfortunately, that's been the case, and that is the case even now. We're studying for sake of marks, we're studying for sake of ranks, and they serve no purpose, because in the real world out there, if this knowledge is not translating into skill set, if this knowledge is not translating into solution forming, then what's the point in gaining all this knowledge? So this is something which we should introspect and then question ourselves, and then let's make a choice. Let's make a healthy choice. Let's make a better choice, keeping our interests and inclinations in mind. So in the clinical examination, the first part of this live session, we discuss certain skin related ailments, right? And then in the subsequent live sessions, after a while, we'll take up the other aspects as well. We'll post even more images, and we'll try to have some textbook review or article review regarding that information. And we'll conclude this live session in a couple of minutes. And once the live session is concluded, we'll start posting some multiple choice questions, hardly 5 multiple choice questions from this particular topic, from this particular discussion, in the community page of our YouTube channel. Okay, you can just keep a tab on it, and then you can get back through mail at proudtobedentist@gmail.com 24/7. And also, before we conclude, we have new courses which we are launching this month, Leo batch towards upcoming NEET MDS 2025 and INSA. So you can drop a mail at proudtobedentist@gmail.com for more details. All the very best. Love you all. Yeah. Gopal, you have daily live session. Gopal, as of now, we are conducting a couple of live sessions every week, and we are posting the schedule in the community page of our channel. So you can just keep a tab on the community page of our YouTube channel. Okay, you'll get the updates regarding when we'll plan a live session. As of now, it is 2 to 3 live sessions per week, and as exam approaches, we'll try considering a daily live session. We used to do that previously, so why not now? Yeah, but as of now, couple of live sessions per week. Seshant, you have a derma question? Seshant, you have any question, you have any doubt, you can use a doubt clarification form and get back through mail at proudtobedentist@gmail.com. Okay, I'll just type the mail ID here. So reach us out through mail if you have any queries related to topics beyond the scope of this live session. Okay, gmail.com. Medicine कौन से टीचर से पढ़ो for final year MBBS? I didn't get your question, Shivam. Can you please post that in English if you don't mind? So are you in final year MBBS? That's good. Yeah. Okay guys, so I hope this session is helpful, and we'll see you again in next live session. And when will be the next live session? We'll come up with an update very soon. So all the very best. Love you all. Good night.